in Melbourne, Florida, and we are getting ready to perform surgery on a patient's back who's had chronic back pain, and he's had leg pain on both sides. Needle is down, 9 cc's injected. The surgery we're going to be performing is minimally invasive outpatient surgery called Deuk laser disc repair. Our patient has degenerative disc disease, herniated disc, disc osteophyte, ruptured disc, extruded disc, extravasated disc, bulging disc. So many different names for the same thing. Annular tears, which is a tear in the wall holding the jelly in. All right, and scoliosis, and a little listhesis, and a bunch of other stuff. But long story short, we did his left side in the past, and his left leg pain is gone. His pain up here is for the most part gone. We tried to do his surgery a few weeks ago, and we had difficulty with his airway, so we had to abort, and we are redoing the surgery today. Shot? Very good. So our goal is to do the right side, L2, 3, 3, 4, 4, 5, 5, 1. And our patient is actually asleep today because, once again, his airway is not one that we can do this surgery with him under sedation. And the sedation we typically use is called propofol, but just cannot do it with propofol. It's not safe. So this is a one-off where we do this surgery with a patient completely asleep. Shot. Like I said, we do not typically do that. And it's usually for safety reasons. We have patients awake, but in his case, to be safe, we have to have him asleep. All right. Now, during the broadcast, you're welcome to ask me questions. Shot. Very close, but his facets are big. I like the angle of attack. The trajectory looks good. Shot. Shot. It's awfully close. Shot. Let's get an AP. So I'm aiming for that little hole down there. You can see it at the back of the disc called the neuroforamen. And I'm probably 1.5 centimeters away from it. So I have to use my X-ray machine to guide the needle, and we actually call that navigation. That's good. So using coordinates to travel somewhere, or the term is called collocate. It just means for two things to be at the same place. For me to collocate the tip of this needle to the disc herniation and osteophyte at L5-S1 on the right side, I need to use coordinates. And the coordinates I'm using are in his spine. I use his pedicle, his vertebral body. I use the X-ray coordinates. You could probably get rid of, because it's a little overexposed there. So to see those coordinates, I need the X-ray machine, and that's what we're doing. We're using this X-ray machine to find the exact spot for me to go. All right. And L5-S1 is always, shot, the hardest. Always. Many doctors won't even try it, shot, because it's so hard to get to. And the reason it's hard to get to is the iliac crest, the sacrum. We're so close there. Let's see what we look like on the AP. I think I'm hitting the S1 superior facet. So I need to be just a little bit more lateral. As you can see, looking at the X-ray, all of the discs are degenerated. Yeah, we're very close. Let's go back. Oh, by the way, on that view, show them the prior laminectomy this patient has. You can actually see the shape of it. It looks kind of like a ghost in the middle of the spine, or something else, like a phallus. But that's the prior laminectomy he had. I did not do his laminectomy. It was done elsewhere prior to coming to me. And people, we talk about laminectomies. Laminectomy is an old type of spine surgery. I personally don't do them anymore because they're so damaging to the spine. They create all kinds of problems for patients. And again, so they create instability, they create recurrent disc herniation, residual stenosis, recurrent stenosis. He had a spinal leak, a leakage of spinal fluid from that surgery, which I did not do, Shot. So I can't take credit for that. Shot. Yeah. Shot. I can already tell he's 5'1" is going to be really challenging to get to. As a matter of fact, that's probably as far as I can go right there. Ooh, let's see. Shot. May have gotten it. AP. The needle is getting deflected a bit. Yeah. It's getting deflected up a little, and I don't want that. I want it to go down, if anything. Right there. He's relaxed.
Yes, he is.
Shot. Yeah, I like that down position better, but I may not be able to navigate with it down. Shot. Right at the back of the disc now. Shot. AP, lateral. So once again, for those of you trying to understand navigation in the operating room, it's where a surgeon uses some physical coordinate, some landmark to basically guide the surgery. I think that's as good as we're going to get it right there. To guide the instruments and the surgery itself. Shot. Could it possibly be? Is it possible that I actually got in? That would be incredible. So during the surgery, you're welcome to ask questions, by the way. Shot. Huh. Give me an AP. Looks like we're in. The dye that I just injected, a very small amount, is inside the disc space, at least on the lateral view, and I got to confirm with the AP view. Yeah, there it is. You can see it running from one side to the other. So we're inside the disc space at L5-S1. At this point, I'm going to place the second needle, and typically with the Deuk laser disc repair in the lower back, we do one incision. I can fix usually 2 or 3 discs. I've never been able to do 4 with one incision. I don't plan to try today. And that's because of the way the spine is lined up. It's called the alignment of the spine. It's just the shape. It doesn't really allow accessing all the discs through one incision if you're doing 4. So usually I can get at least 2 or 3. Shot. Good. So we're going to go for the next disc, which again is very collapsed. And Jordan is doing his very best to show me the anatomy. Shot. Once again, I'll come down onto the facet joint. Shot. And I will touch the facet joint and then go around it. Shot. Shot. Any questions from our audience so far? Shot. I want to welcome Henry. Shot. Henry has joined us and has taken over the videography and broadcasting position. AP. And Flynn is still helping train him. So the good news is we're back up broadcasting. We've found a great videographer, video editor. producer, director. Should I keep going?
No questions yet, doctor.
All right. Are we good? So that AP view looks pretty good. Yeah, we're very close. We're certainly in good position. Now, let's see if I can get into that disc, because that's going to be another really tough one to get into, just because of the amount of arthritis that's there. Shot? You know, it's amazing, huh? Having the patient relaxed, really, I can get into the disc, even the collapse ones, much easier. Not suggesting we do general anesthesia every time. Yeah, of course, but I don't get feedback from the patient. That's the problem. All right, we've done accessed. Horrible. It's the South. We're done accessing, or we've accessed, past tense, the L4-5, L5-S1 disc, transforaminal from a right approach. And remember, this patient has big herniations in the foramen, and they're hitting on his nerves, and he's got bad leg pain. He had really bad neurogenic claudication on both sides, and that's basically leg discomfort with walking and standing. Gets better with sitting, and that's one of the main reasons he came to us for this surgery, because remember, he had a laminectomy, right? What a laminectomy is supposed to fix? Leg pain, neurogenic claudication. So he had the laminectomy, and now he's back having another surgery. Again, this is why I tell people don't do laminectomies. Shot? They don't work. They don't work long term. Shot? And they create tremendous arthritis and instability of the spine. So they just create problems, structural problems. AP? Now I probably could get this disc at 3-4 through the same incision, and then I'll probably have to make another incision at the next disc. It's looking good. Yeah, let's go back to a lateral view. So you can see the 3 needles all coming together at one spot over to the right side. Well, that's where the skin incision is. I'm not going to be able to get the next disc through the same incision. If you look at the angle of the disc, you can see it's almost impossible to reach through the same incision. Shot?
Dr. Deuk, we have a question from Rick on Facebook.
Hello, Rick. We'll take your question.
He's asking, I was told I have arachnoiditis. Is there anything that can be done about this?
So, Rick, first of all, I would strongly recommend you submit your MRI to Deuk Spine Institute. Reason why? Because if you don't have arachnoiditis, you want to know what you do have. Most sources of back and leg pain are totally fixable. There's one that's not. It's arachnoiditis. Arachnoiditis, basically, for those of you who don't know what it is, it's inflammation around the nerve roots within the thecal sac. The most common cause is basically inflammation that's caused by a procedure called a myelogram. That's why we don't do myelograms anymore. That myelogram dye can cause arachnoiditis. What happens with arachnoiditis is that the nerve roots stick together. Local? And arachnoiditis causes horrible leg symptoms like pain and burning, usually burning in the legs. It's constant. It doesn't fluctuate. That's the key. Now, if your symptoms fluctuate, get better and worse with movement activities, it's not arachnoiditis, okay? It's not. Arachnoiditis symptoms never change. They're constantly burning and hurting. So I don't know what your symptoms are, but my advice to you is go ahead and post the link for Deuk Spine's free MRI review, and I would recommend you send us your MRI for a free review. It's mri.deukspine.com. Anyone's welcome to send their spine MRI to us for a quick evaluation to see like what exactly is causing your symptoms and what can be done to fix it. Now, if you do have arachnoiditis, the treatment for it is spinal cord stimulator. That's the best treatment available today. But this surgery here will not fix symptoms of arachnoiditis. So, unfortunately, I'm sorry. My best advice to you is have Deuk Spine do an MRI review and verify that it is indeed arachnoiditis. But I can tell you right now, as a patient, If your symptoms are constant burning 24/7, no change, no fluctuation, they're just always bothering you, then it could be very well be arachnoiditis. On the other hand, if your symptoms are, back to a lateral, if your symptoms change, they get worse with walking and standing and activities and better when you take it easy, then it's not arachnoiditis and it's fixable. If it is arachnoiditis, I recommend you see an interventional pain management doctor, spine surgeon, to talk about spinal cord stimulator. Shot? Great question. Thanks for contributing. So right now I can feel something hard right there at the tip. And guess what? That's where the herniation is. Now he was so happy with the first surgery we did on the left side, we got rid of his leg pain in the left leg. Unfortunately, he also has pain in the right leg. We were trying to do that surgery several weeks ago, but we had issues with sedation, and we didn't want to proceed because we felt it was too risky, so we brought him back and put him to sleep. All right, we're going to do our discograms at this point. We're basically where I inject some dye into the discs, and shot. That allows me to see the tear better and repair the annular tear. Remember, the Deuk laser disc repair surgery you're watching does two things. It unpinches the nerves that cause leg pain, and it treats the back pain as well by fixing the annular tear. All right, let's get a quick AP. We've so far lost 2 drops of blood. That's all. We're probably going to lose about 10 drops of blood for the whole surgery, which is nothing. Open back surgeries lose hundreds and hundreds of cc's, even thousands. Shot? Yeah, perfect. It couldn't be better. Very happy with these results. We're going to start with what, L5-S1? I say we start with 2-3, work our way down. What do you think, Luis? So, for those of you watching, it's a bit of an unusual surgery in that we're doing 4 discs, 4 spots, but this patient has 4 annular tears and 4 herniations. Okay? And we started at, we're starting at L2-3, which is the highest disc. And I'm going to draw these discs for you so you can see where they are. The L2-3 disc is right around here. It's a cushion between 2 vertebrae, the number 2 and the number 3 vertebrae. Then the next disc is L3-4, and then L4-5, and then L5-S1. So this patient had an annular tear in the wall at all 4 discs, and the jelly from the center has pushed out and is now hitting on the nerve roots. We call that a herniation, but over time that herniation is turned hard, rock hard. We call it calcification of the herniation, and the other name for it is a disc osteophyte. Osteophyte means bone spur. That's the calcification part. So he's got 4 herniated disc osteophyte complexes hitting the nerves, and that's what we're going to go fix. All right, any other questions? Shot?
No current questions, doctor.
All right, go ahead and run the video, Shot, that explains why herniated discs cause back pain and leg pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, so at this point, you've watched the video. You can see why people get back pain. The most common cause of back pain, folks, is not what you think it is. It's actually the tear in the back of the disc where the herniation is. And that tear is where the herniation comes out. And as it comes out, it literally irritates the heck out of that tear. And that causes pain from the disc itself. So the video shows you that chronic back pain comes from inflammation within the posterior annular tear. And that's what I discovered at Deuk Spine Institute almost 20 years ago, 16 years ago. And we've been doing this surgery for 16 years. We've done over 1,400 patients now. And you can see there's no blood loss. The whole surgery is done through a little tube. See this tube right here? We're literally going to repair that disc through the tube. Now, let me show you something. If I had done an open back surgery to fix him, you can actually see his scar. It's from here to here. If I had to do open back surgery, the incision would be this big, that big. But instead, we're doing 2 7-millimeter incisions. When you do the incision this big, you got to peel all the muscles off the spine. And guess what that does? It kills the muscle. So the patients end up with dead muscle and scar tissue instead. So they get a ton of scar tissue with open surgery. With this surgery, there's no muscle being killed. There's no scar tissue being formed. Not in the muscles or the spine. All right, we are ready to go. We've got our tube in place. This is endoscopic spine surgery. This is true endoscopic spine surgery. And for the lower back, we call it transforaminal. There's also interlaminar, which is bad. You don't want interlaminar. Interlaminar surgery destroys the bones and ligaments. Transforaminal, we're going through a normal, natural opening that's already there. Okay, great job, Luis. So we're grabbing out some of the herniation. We're inside the disc, by the way, for those of you who are trying to figure out where we are. We are literally inside the damaged disc, and I'm grabbing out loose pieces of herniation. You see, there's not much disc left. Everyone asks me all the time online, but Dr. Deuk-Majan, don't we need to have a cushion between the bones? Don't we need disc material? The answer is no, you don't. For many years, I believed that you did need that. I was taught the same thing. But the reality is, there's lots of people out there that have no disc left because it's so degenerated, and they have no pain. So we don't do this surgery to give people the cushion back. There's no surgery that's going to give anybody their normal disc back. The best we can do is put a metal disc in there, and metal discs pop out. Metal discs don't solve any problems. Metal discs only act as something to make the surgeon and patient feel better by seeing that there's a metal disc there. But it actually doesn't do anything to help the patient at all. So I'm totally against artificial discs. I think they're completely unnecessary. I'm also against fusions because I think they're unnecessary. And years ago, that's all I used to do was fusions. I did fusions because that's all I knew how to do to fix people. By the way, show them the herniation. Can you see this here, guys?
Yes,
With
we
the
can,
video?
Doctor.
That's a piece of herniation that just came out. It's stained blue because it's a piece of degenerated nuclear material. What happens when the herniation forms, the nucleus pulposus or center of the disc pushes out through an annular tear, either in the back or on the side of the disc or even the front. And the herniations that happen in the front or the sides of the disc don't cause any symptoms at all. No pain, no nerve damage or nerve compression. It's only the herniations in the back that cause problems in the back of the disc, like the ones we're fixing today. All right. Seem to be a fair amount of air bubbles. Maybe it's, because of suctions. I don't know. Not sure why. See all those air bubbles? Any idea why? All right, so there goes another piece of herniation out. I'm using the laser to free up the herniated fragments. Otherwise, they won't come out. They're very hard to get out without the laser. The laser is very important to do the debridement. I get another question from people, why do you need a laser? I've heard lasers are bad, lasers are dangerous. They're not dangerous. People that tell you lasers are dangerous are the doctors that don't know how to do laser surgery because they've never done it. They just don't want you leaving them and leaving their office where they're going to offer you a fusion or metal. They just want that money for doing your surgery. And that's, to me, unethical. If a doctor wants to have an opinion about laser spine surgery, they should become an expert on laser spine surgery and have an opinion then. Okay? It doesn't mean they have to do laser spine surgery, but they should know everything about it. And if they know everything about laser spine surgery and they know about this procedure, the Deuk laser disc repair, they would be telling the patients to come and have the surgery done. Because it's far better than anything they can do. Far better than fusions, far better than laminectomy, far better than microdiscectomy, far better than artificial disc. There is no other spine surgery better. Now look at this. See the pink tissue? That's where all the pain comes from. That is the granulation tissue, full of little nerves that are pain nerves. It's totally inflamed from the herniation being there, causing that annulus to turn pink. The pink tissue is not the nuclear material. It's not the actual herniation. It's quite literally granulation tissue from chronic inflammation. All right, any questions from our audience? Now today is, what is it, April 26, 2022. So if you're watching the surgery today, you may be watching a live stream. We do live streaming because we want the audience to be able to ask us questions during surgery. You know, the most effective, look at the pink tissue, guys. This is huge right there. You see that? That's where all the pain comes from. Sometimes we don't see it that well. It's kind of hidden. But today we see it very nice. But that's what we're after when we do the annular debridement.
No questions yet, doctor.
Yeah. It's not possible to remove that without the laser. Typically, the first discs to go and become injured in people is the L4-5 and L5-S1. The L2-3 is one of the last to ever be affected or injured. This patient has L2-3, L3-4, L4-5, and L5-S1. So he got the full house. Now, if he had L1-2, he would have the royal flush. If you're a poker player, you know what I'm talking about. I like playing poker. I've played poker most of my life. Back in college, that's what we used to do on Friday night. We get together with with everybody, and we sit down and play poker. And we'd bet real money. You know, in your friend's garage, of course. But we would play poker games and entertain ourselves. Nowadays, I don't see that happening so much with the younger generation. They're too busy with their phones, you know? They just want to sit down and get on their phone and spend their Friday night on Snapchat. And it's sad, you know, because it really does promote what I call social awkwardness for kids these days. Because when it comes time to actually interact with their peers, they have a hard time because they're so used to interacting with them over the phone that face-to-face interactions can be a bit awkward. We all go through it. We all go through it in our lives. We all feel awkward at one point. But it's a necessary thing to do to develop properly, emotionally and psychologically. My son just had his prom this weekend. Prom? Yeah. And I remember he was looking forward to it so much. They had it at SeaWorld for his high school. I guess they have it at big parks nowadays since we're in Orlando. When I was a senior back in the 80s, we had a senior night. We all went to Disney. I think it was Disneyland back in California. And then we had prom as a separate event. Of course, we had ditch day, right? So it's interesting now to see my kids kind of going through the same phase where they have their senior day and they have prom and they don't really have senior night. So I was surprised at that. I guess they consider their prom night senior night.
Rick from Facebook has a question.
All right, Greg, what's your question?
Rick says,
Rick.
What can you tell me about Scheuermann's disease?
What can I tell you about Scheuermann's disease? Well, there's not much to tell you about it. It's a condition that affects the spine, and I don't think that it causes symptoms. I know there's people that believe it causes pain and dysfunction, but from my understanding of it, I've not seen it really that often, to be quite honest with you, in patients. So I think part of the problem, to be honest with you, is that there's a lot of doctors out there that make the wrong diagnosis as to what's causing the patient's pain. For example, fibromyalgia. Fibromyalgia is a condition where pain is coming from soft tissues and it's not fixable. There's no cure. But there's so many people diagnosed with it as the source of their pain when it really is not the source of their pain. Their pain is coming from their facet joints or their disc, and yet they've been misdiagnosed as fibromyalgia. So I think of Scheuermann's disease as kind of the same thing. It's something that we see radiographically, but it's not really a cause of symptoms. I probably have seen, I see Scheuermann's quite often, that it's asymptomatic, meaning not causing symptoms. So we do nothing for it to treat it, because treating it doesn't resolve the patient's problem. I don't know if that's helpful to you or not, but that's the practical worldview of Scheuermann's disease for me, in my practice. The problem is, and that's why we do this broadcast, the problem is so many people out there with pain are being told the wrong cause of their pain, the wrong diagnosis. And that's why we do the broadcast, so you can hear my opinion on it. And if you were to send us, Rick, an MRI scan of somebody with back pain, I could tell you why they have back pain by looking at the MRI and by performing a physical exam virtually. We do that quite often at that MRI at dukespine.com, and we're able to figure out why people have pain. And it's never Shorman's disease that's the cause. It's never fibromyalgia. There's always a fixable, treatable reason. And it's usually a bulging disc or a herniated disc or a facet joint. Facet pain and disc pain are the two most common causes of pain. And they account for, in my experience, 98% of people's back pain. Some people have one, some people have the other, and some people have both. But 2% of back pain comes from fractures, tumors, infections, ankylosing spondylitis, spondyloarthropathies. So my advice to you is whoever you're asking for, they need to get a good diagnosis as to the actual cause of their pain. And Shorman's disease, in my opinion, is not a cause. It's just a radiographic finding.
We have a question from James on YouTube.
All right, James, we'll take your question.
I have an L5-S1 disc herniation, and he's been in spasms for almost 6 days. What can you do for me?
Yeah. So you have a herniated disc at L5-S1 and you're having pain for 6 days. If you were my patient, I would first examine you. I want to know, do you have any weakness in your legs? Is there nerve involvement or not? If there's no weakness, no numbness, then, and we're just dealing with back pain, then I would put you on a muscle relaxer and an anti-inflammatory and maybe a low dose narcotic, and I would get you into some physical therapy to stretch you and give you about 4 weeks of PT to see if it improves. Now, physical therapy is not going to improve your pain from a disc, but what it does is it keeps you limber, it keeps you from laying in bed and just basically getting worse, getting those muscles and joints deconditioned. What you need is you need to give that disc an opportunity to heal itself. Your body can heal herniated discs sometimes, and that'll cool it off, and you'll feel a whole lot better if your body does heal it. On the other hand, if you continue to have pain over those 4 weeks and it's getting worse, or you develop leg symptoms, pain or weakness in your legs, numbness in your legs, then I would definitely recommend, you got to tell me when you're changing the fluids. No, you have to. Because what happens if you don't is I turn the laser, keep the laser going, and it runs dry, and then it literally could actually break the scope and cause problems. So that's quite all right. There's a reason I'm always notified. All right. So, but thank you for wanting to preserve my ability to teach. Okay, that's what I would do. So the most important thing is figure out if the patient has neurological deficits, which is nerve compression that's severe and could cause permanent nerve damage. And that would manifest itself as dragging your foot, weak foot, but you need a doctor to evaluate you, like a spine surgeon or a neurologist, who can check you out and make sure you don't have any of those weakness. Okay? But if there's no weakness and we're just dealing with pain and muscle spasms, then yes, a muscle relaxer, anti-inflammatory, low-dose narcotic, and physiotherapy. Stand by. So this disc at L2-3 is different than the L5-S1 and L4-5, which are more collapsed, more degenerated. This disc has more of the soft herniation that I'm dealing with right now, trying to get it all out. Whereas the L5-S1 really won't have much of this at all. And neither will 4-5, because they're pretty advanced degeneration of the disc. I don't want to leave any loose things in there. I want to get everything out. You can see this is the back of the annular tear. This is the furthest back part of it right here. And I'm doing what's called an annular debridement. I'm debriding the annular tear using the laser. This is the signature move for the Deuk laser disc repair. This is what I pioneered. This part of the surgery. Actually, most of the surgery is the annular debridement. So pretty much when you see me going in and grabbing things, that's the removing the herniation. But when you see me with the laser, that's the annular debridement.
Trevor from YouTube has a question.
Hi Trevor, welcome to our broadcast.
He has asked, what is dish disease?
Oh, what is dish? Yeah, so dish is diffuse idiopathic skeletal hyperostosis, okay? And like Sherman's disease, it really doesn't cause any symptoms 99% of the time. It's just basically growth of bone around the spine, and as the name suggests, diffuse, meaning like everywhere, like diffuse, not just localized to one spot, but everywhere. And idiopathic means we don't know why it happens. As doctors, we haven't figured it out. Skeletal, because obviously it's affecting the spine, or spinal, because it affects the spine. And then hyperostosis. Hyper means too much, like excessive. Ostosis is formation of bone. So dish is diffuse idiopathic skeletal hyperostosis. You don't need treatment for it. It doesn't cause any symptoms. Guys, if you have pain in your back or your neck, you're wondering why, send your MRI to Deuk Spine Institute. We'll tell you why. But it's not dish. It's not Shorman's disease. There's a lot of misinformation out there. That's why we do these broadcasts, to help people get answers, get help, get better, get healthy. All right, just about done here, but this herniation just keeps dropping. Almost done at this one. Probably another 2 minutes. Great question so far. So what I'm looking at here at 12 o'clock, that red stuff, are veins in what's called the epidural space, which is just behind the disc. And then that web of white tissue is connective tissue behind the disc. And this stuff here is all part of that scarred up annular tear and herniation. So I'm trying to get rid of as much of it as I can with the laser. And literally to the right is where the nerve is, the L2 nerve root. And to the 12 o'clock higher up is where the what's called the traversing root is. That's going to go down to the L3 and exit. So I'm working between the two nerve roots, the exiting root that comes out at this foramen and the traversing root, which goes across at 12 o'clock. And I'm in an area called Cambin's Triangle, aka the safe zone. And Parvis Camden is an orthopedic surgeon that was the first one to really use this safe area to get in and treat herniated discs that are far lateral. And with improvements over time, we're now able to treat more disc herniations, even paracentral disc herniations, and eliminate back pain and leg symptoms through this approach. All right. Gosh, that's pretty much it. You can see that I've gone all the way through the annulus there, right there, and just what's left is just a thin rim of annulus that's scarred. I don't see any more herniation. So laser off. Let's take a look and see if we can see the nerve root, the L2 nerve root. It's going to be right. Whoa, no. Laser off, laser off. All right, there's a little bit right there. That's quite all right. You're learning. No harm, no foul. Yeah, so laser off and scope off are two different things, but you're fine. Trust me. You didn't do anything bad. All right. A lot of fat right there around the nerve root, around the dorsal root ganglion. Pretty much done. I don't see anything more that I can remove. There's no more herniation. So. Great questions from our audience so far. Scope off. I'm going to put a little antiseptic down here. We use betadine. Yeah, that's good. Nice job. I only use one syringe, you know, right? Yeah. And I learned too. You really don't need more than one syringe for the case. You know what I mean?
Yes, sir.
So, betadine is an antiseptic developed by NASA, and basically it's probably the most powerful topical antiseptic known to man and women, of course, and everything else. But basically what I'm getting at is NASA developed it because they were afraid when the space shuttle came back to Earth from being out in space, it could bring some crazy virus or bacteria with it that would kill everyone. And so they developed a very powerful tool, this antiseptic, that very, very effective against bacteria, viruses, fungus, anything that, you know, these pathogens that are microscopic that you can't see. Of course, if they were to bring back the alien, then that wouldn't be effective against the alien because that's not a microorganism, right? That's a macroorganism.
Yep.
Right, Dr. Berndes? So we've used the same antiseptic that NASA uses and NASA developed because it's commercially available. Lateral, always lateral. I was talking in some of my prior broadcasts about the antiseptic we used to use for these surgeries was bacitracin, 50,000 units per liter of irrigation,
Are we going to need the X-ray and the...
and polymyxin. And unfortunately, bacitracin is no longer available, so we've had to switch to this betadine, which I think is probably just as effective, but you know, certainly readily available. A lot of surgeons aren't using any antibiotic at all in their irrigation anymore. I think that's a mistake. All right, shot. So we're going to go to L3-4 next, shot. You can see the guide wire there that just came out of the needle. I'm going to pull this needle out, and we've got the guide wire in place. I'm going to bring this dilator. Now look, you guys see the tip here? It's shaped like a pencil, and what it does is it spreads the tissues open. It gently, without trauma. That's why there's no scar tissue and no bleeding, because it's atraumatic, meaning no trauma. unlike major back surgery where you're ripping the muscles and spine open and tearing out ligaments. Shot? All right. Shot? That's beautiful. That us? Yeah? Take? Uh-huh. Now, the dilator's in. It's right where I want it, inside the tear, inside the disc at L3-4. But I can't do the surgery through it because it's solid. So I need a tube that I can actually put the scope down, and that's what this is. It's called a tubular retractor. It looks like a McDonald's shake straw. And I'm going to just slide this down the dilator. And we call this a tubular, a graduated tubular system. I did not develop it. It was developed by somebody far smarter than me, but I use it. And it's part of many types of spine surgery, but most spine surgeons use a bigger one, a much bigger one. And that bigger one does cause trauma to the tissue. It causes ripping of the muscles, damage to the muscle. It causes bleeding and scar tissue. And so I use the smallest, narrowest tube possible to do spine surgery. There's not many surgeons in the world that can do surgery in the spine through a tube this small. There's a small group of us. We're the true minimally invasive surgeons. Of course, most other surgeons that are not trained on this technology, they'll tell you that they're minimally invasive surgeons, but they're not. They can say all they want, but they're not really minimally invasive surgeons. So consumers should be aware, patients should be aware. If you want true minimally invasive surgery, you have to find a surgeon that does this transforaminal Deuk laser disc repair. All right. Look at this herniation, guys and gals. Can you see it?
Yes, we can.
Do you see it with the eye in the sky? I don't mean through the endoscope. Look through the eye in the sky.
We can see it, but the light is in the way a little bit.
Oh, pull the light back, please.
No, it's probably the lack of the scope, actually. Yeah, turn on that light. Yep. There you go.
That's perfect.
Yeah, you can see how big that is. That's a big, big herniation. And that's what we can do. We can take these herniations out, but I can actually see them. See, when surgeons do microdiscectomy, they can't actually see the herniation. They just grab down there and hope they grab something and pull it out. How do I know? Because I did microdiscectomies. As a neurosurgeon, that's what I was brought up on, was microdiscectomies. It's just that I've moved on to better technology, whereas most other surgeons don't. They just stay with what they learned many years ago. But that's old technology, and it's very damaging. It's very damaging for the patient. Okay? So what I'm getting at is, if you really want, there's a big herniation right there. I can't even get it out. You see it? If you want what's best for yourself, then you're going to find a surgeon who's keeping up with the latest. Here comes a big one. Okay, get this right here. Turn the light on. Can you use the eye in the sky? Can you see this hole? I need feedback from my...
Yes, we can.
All right, here it comes. Let's see how big this thing is. Oh, yeah. That's another whopper. See that?
Yes, doctor.
Pretty cool, huh? So, 2 really big herniations at L3-4. Huh? Yeah, oh yeah. Yeah, for sure. But there's lots of other pieces. They just keep coming. This poor man blew this disc out pretty bad. Oh, there's another name too. I mean, a lot of this is also, some of it's herniation that was in the foramen, and I pushed it into the disc to get it out. That was taught to me by Dr. Tony Young, Dr. Anthony Young. It was his technique, what's called the inside out, where you start inside the disc where it's safe, and you just kind of push the herniation into the disc, and then you deliver it once you get the tube in, to safely pass the nerve roots in the foramen. So this is called the inside-out technique of removing herniations. And in contrast to the outside-in technique that other endoscopic spine surgeons use, where they start in the foramen and work their way down to the disc herniation. I think that's a far worse technique. I do not do it. I don't think it's safe. But there are surgeons who do the outside-in technique, and they will argue with me that their outside-in technique is just as safe, but it's not. All right, so far so good. Wait, I'm going to adjust the position of this tube. You can see the tear right there in the annulus. It's a big tear. This is where his back pain comes from, and this is where the herniation came out of. So we're going to use a laser now to facilitate removal and debridement of the herniated material. See that blue thing? That's herniated nuclear material stuck inside the annular tear. It has a special name. It's called the interposed herniation. Interposed. Because it is interposition between the tear, the left side and the right side of the tear. Basically, it's stuck in the tear. Again, we're Deuk Spine Institute here. We're broadcasting live from Florida, specifically near Orlando. And we are in the Space Coast of Florida. If you're following the news, Elon Musk just purchased Twitter. Actually, him and a group of investors just bought Twitter yesterday. So that's what's happening in the world. I have a lot of admiration for Elon Musk personally. He's the kind of person who, when he sees something he doesn't like, he goes out and fixes it. Very impressive. Not many people are like that. Anyway, there's another herniation right there. That's a big one. My gosh, this disc is just destroyed. But that said, he will do great with this procedure because we're removing all these chunks that are causing problems. If I can grab it. So Elon Musk, as many of you know, is the founder and I guess major owner of a company called SpaceX. SpaceX is located here. One of their branches is located right here where we are in Melbourne, Florida, Merritt Island specifically. And this is where they launch all their satellites because we're in the Space Coast of Florida. It's called the Space Coast because this is where the gateway to space is in the United States. Okay? What that means is this is where NASA has been launching the space shuttle and the military has been launching all their military satellites and all the telecommunication satellites are launched from here. And there's a reason for it. Does anybody know that reason?
I think it has to do with the weather and
Weather? Nope.
weather's a big role.
Nope. It's not the weather. Yeah. Anybody?
Trajectory, the coast.
Yes, yes. And you're getting hot. Trajectory. What does it mean by trajectory?
Accessing the orbits.
Yeah. You can launch 10,000 pounds more payload from the East Coast of the United States than anywhere else in the United States and most of the world. I don't know why, but it has something to do with the way the Earth rotates. It allows heavier payloads to be brought to space. How do I know this stuff? Well, many of you don't know this, but I actually worked over at NASA for years as one of their doctors for the launches of the space shuttle during the shuttle program back in the late 90s and early 2000s. From about 1998 to 2002, I was involved with the space shuttle program as a doctor, part of the medical team basically that was there during shuttle launches and landings to take care of the astronauts if something bad happened, if spaceship blew up or landed wrong and crashed, we would have to, after the astronauts are extracted out of the orbiter, and then decontaminated, we would be ready to administer medical care. We always had an anesthesiologist, we had an ER doctor, and we had a surgeon, which was me.
I was a flight surgeon for years.
Oh yeah? Nice. Sometimes we'd have two anesthesiologists, you know. But it was always an ER doctor, a surgeon, and an anesthesiologist or two. A team of 4 of us. So it's pretty cool. I miss those days. But I've gotten busy here at Duke Spine anyway, so. But quite literally, you could be at near NASA in 10 minutes, 15 minutes. Depends on how fast you drive. All right, any more questions?
No more questions. Doctor.
All right, so let's run the video then on what we're doing here with the laser surgery at the back and how the Deuk laser disc repair works to cure back pain, cure leg pain that comes from a disc injury.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
Yep, you can. Yep, thanks for letting me know. Good job. All right, we're switching irrigation bags. You'll see bubbles in just a second. And once I see the bubbles, I'll proceed. It started, right? There are the bubbles? All right. Sometimes it actually goes dry completely, and in which case you don't want to be firing the laser in a dry socket. Otherwise, it can actually damage the laser, damage the scope. So I have to wait for those bubbles to come and go. We were just talking a minute ago about how big the herniations were at this level. They were the biggest at this level so far. We've only treated 2 levels, the L2-3 and this L3-4, but we're going to get to L4-5 and L5-S1 in a few minutes. This is sort of the back end of the tear right here, you can see, and then it goes into the epidural space where the nerves are. So we're just about done with debriding this particular disc. So far, this patient's doing fantastic from a surgery standpoint, and I know Dr. Berndes is very happy with his anesthesia, correct? He's stable, he's happy, patient's safe, patient's doing great. I think this is going to be a really good surgery for this patient. Now, he traveled from Fort Lauderdale, or where did he come from?
Pompano Beach.
Pompano Beach.
He's my neighbor.
No. Your neighbor down there, huh?
So I grew up in
You grew up in Pompano Beach area?
Boca Raton.
Is Pompano Beach close to Boca?
Yes.
Let's see.
One town.
I know the name Pompano Beach because I've gone to Miami so many times for racing.
Oh,
And we always stop at the Pompano Beach, what is that, rest area? Right off the highway there. It may actually be a newer one. But yeah, we've stopped there many times. You got married in Pompano Beach. Wow. Dr. Berndes is giving us some history. Did you get married at the rest area? Just kidding. You would add you got happily married in Pompano Beach, right?
I got married at one of the few lighthouses remaining in the state of Florida.
You got married at a lighthouse.
Lighthouse Point.
Well, why did you choose a lighthouse? I'm just curious.
It was adjacent to the resort.
Huh?
It was adjacent to the resort where we had it.
Oh, yeah? Whose idea was it to get married at a lighthouse?
Both of us, we liked it.
You both like lighthouses?
Showed us the way to have there.
I like that.
So there's actually a town at Pompano Beach, a very nice small town called
Uh-huh.
Lighthouse Point, because it's named after where it comes out into the ocean is where the lighthouse is. There's a jet.
Oh, nice. Yeah.
Beautiful.
So Dr. Berndes is giving me a little history on Pompano Beach and the lighthouse there. So if you're interested in a wedding idea, maybe Pompano Beach Lighthouse. All right, we're just about done here at L3-4. I want to do a little bit more with the laser. So some people ask me, Dr. Deuk, is the Deuk laser disc repair procedure FDA approved? The answer is yes, 100%. Everything we do at Deuk Spine Institute is FDA approved. We don't use anything that isn't FDA approved. All of our supplies are FDA approved. Everything we do is FDA approved. Deuk Spine Institute and the Surgery Center where we operate have been licensed in the state of Florida to do surgeries now for almost 10 years. And we always get inspected every 3 years by the government. And we've always passed our inspections with flying colors. The inspections are usually done by an engineer and a nurse. And they love our facility. They say this is the nicest ASC we've ever seen. That's what we hear all the time. ASC stands for Ambulatory Surgery Center. And a lot of that I have to credit to my staff, my team, doing such a great job. The nurses, Luis has been here, he just told me 8 years, right? I think only, Foley is the only one here longer than you? Monica. And who? Sarah has been here a long time, hasn't she? All right, we got another massive herniation. Just incredible how bad this disc is. I can't even get it, it's so big. It doesn't want to come out easily. So, look at that thing. It's like a rock. That's definitely... I have to do it. Anybody know? Oh, anybody know what that's called?
Scope up, please, scope up.
No, scope on. I want to go look.
Okay.
Let's see how far out we came. We may have to redo it. Oh, cool. Yeah, we're definitely out. Wait, maybe I can get it right there. What do you think? Yeah, that's it. All right, hold the tube, please, so it doesn't come out. Okay, can you do that? Yeah. When you see me fighting, it's a good idea to grab the tube so it doesn't come back. All right. So what I was going to say, you got it? It's going to tug. Yeah. There's another herniation. That's probably the last one that I can see. What I was going to say is that maneuver is called the death roll. And if you live in Florida, you know what a death roll is. Everybody know what a death roll is? Luis, you know what a death roll is? What? How is that possible? A death roll is when an alligator bites its prey and then starts rolling, spinning. So you see how I grab it with my teeth here and then I twist it. So that's a death roll. Anyway, I thought everybody knew what a death roll was. All right, relax. Just about done. I need 10 seconds. We've gotten all the herniations out. I can't see any more. By the way, see how wonderful it is to actually see all the herniations inside the disc, outside the disc? Literally, you can't do this with microdiscectomies. Surgeons can't see this detail. They're just guessing. But that was pretty cool, huh? We came out into the muscle a little bit and we could see some arteries. Like we saw a muscular artery. Did you see that? I'll show you guys again. We don't do that very often, but we'll take a moment to do that here since we're almost done. All right, take that. See, so we pull back a little bit and we kind of see some of the arteries here. This is all fascia around the muscle. There's an artery right there. You see that? Pretty cool, huh? Look at it pulsing. Boom, boom, boom. Love it. Love anatomy. If you want to be a surgeon, you got to love anatomy. Yeah. We're done. We're done with this disc. Scope off. All right, any questions from our viewers? Again, we'll use a little bit of antiseptic, that betadine. Yeah, I need the irrigation.
No current questions as of now, doctor.
The viewers know everything. All right, so far we've shown you videos of the herniated disc and the annular tear, how it causes back pain. The number one cause of back pain, about 75% of back pain comes from herniated discs in patients. The other 25% or 20% comes from facet joints. We treat both here at Deuk Spine. What's wrong? All right. So we're done with 2. We're going to take this out and move on to number 3, which is the L4-5. Come on in, Jordan. Hey, Luis, do you think it's worth covering this lumens pedal at all with like a plastic bag?
We can.
I guess I won't be able to push on the thing. I don't know. I'm just wondering, do you think it's okay? I know it's waterproof.
Yeah, this one. I mean, yeah.
Should be fine. And we have a backup. We have 2, right? It's just hard for me to watch something that's, you know. All right. We're going to move on to the next disc, L4-5. All right now, Luis, maybe next case. Yeah. I'm just thinking out loud. Could be overkill, but
Alright, so let's switch slides, please.
here we go with the guide wire shot. Perfect. Shot. All right, you can see the guide wire there. I got to leave the guide wire in and take the needle out. Oh. Excellent. All right, so we bring our dilator down. Shot. Again, I can feel hard bone spurs here. Now remember, L4-5 is different than the one we just did. It's more degenerated. It's basically more collapsed, more arthritic, more bone spurs, more scar tissue. Yes. You have a question? Shot? You have a question there, guys? No? So, Henry, I can't really hear you. I don't know if you're talking or not.
I am now.
Okay, so I was asking if you guys had a question at all, but I didn't get a response.
Apologies. There is one question from Ernest on Facebook.
I love that name, Ernest.
And he says, is the death roll the alligator death roll?
Yes. Yes, the death roll I'm referring to is the alligator death roll. You are correct. So I was trying to pull the herniation out. It was too big, but I got my teeth around it like an alligator gets its teeth around its prey. And then because I couldn't pull it out, I started to twist it and kind of roll it in an effort to get it to come up the tube, you know, like to get all the pieces within the tube and get them coming up. So I made a reference to an alligator death roll because we're in Florida. We have lots of alligators. None at Deuk Spine Institute. All right, so far this patient's doing well. He's stable. Surgery is going well. I'm very pleased. Oh, that's going to be a tough one. There we go. And we have lots of these tubes, right? So this disc, as I said before, is extremely collapsed. We call it degenerated. Another name is spondylitic. And of course, more degenerated discs tend to have more bleeding as well because they have more inflammation. The good news is for us that these kind of discs typically don't have a lot of disc material or herniation. They have still the annular tear that's the source of pain, and they have bone spurs. Look at that, little bit of herniation right there. Not done yet. Any, oh yeah. I'm surprised to see that guy. Is everything okay? Yeah, I think we're all right. I mean, I think having the muscle relaxation with the general anesthesia, since we're ventilating him and we need muscle relaxation, I think that's really helping, you know, to get into the space. All right, starting our third disc repair on this patient. This is the number 4-5 disc. I got it. Yeah, thank you. I understand. Yeah, the tense up is not that big, but it's kind of the chronic, you know, when you stretch a muscle and hold it in stretch, it continues to fire. It continues to tighten. It doesn't just release right away. So that's why they get this compression of the disc. And if it's already collapsed, it makes it really hard to get the tube in. Yeah, we were just talking, we've had a few patients who are pretty big, usually men with lots of muscle in their backs, and you know, if they tighten up on the tube, they can actually crush the tube. The tube is thin. It's a thin-walled stainless steel tube, but like right now, I'm feeling a lot of pressure on the tube, but as I bring it further back, that pressure will diminish. So we're okay here. But we've had patients who will literally crush a steel tube between their vertebrae. They're so hard. Their vertebrae are so tough and strong, and the muscles are in spasm. So just about back to where I need to be. I apologize for the visibility issues, but this, remember I told you this is a far more degenerated arthritic joint, therefore it's got more blood supply, and because it has more blood supply there'll be more bleeding. Nothing I can do about that. The bleeding you're seeing is literally very, very minimal, but it's just filling the irrigation and kind of tainting it red, so it makes it a little bit harder for you guys to see. Makes it harder for me to see too, because I'm seeing everything you're seeing. It's just that I've done so many of these surgeries that fortunately I know what to do. I stay focused on getting the job done. I remember the first time I had some bleeding during the surgery. This was years ago, 16 years ago. It was around my third case. And I had a pretty good amount of end plate bleeding, just like that right there. And I couldn't see anything, and I didn't know what the heck to do. So I tried a bunch of things, like increasing the irrigation. I tried putting this thing in, this grabber, and it seemed to stop the bleeding when I went in, because it kind of creates a back pressure so you could see easier. I tried thrombin, putting thrombin in there. Gel foam, I stuck gel foam and thrombin down the tube. But then I ended up just waiting, and it stopped bleeding after about 2 minutes. And I realized, you know what, there's not that much blood coming out. And over the years, I kind of learned what I needed to do. Always is at 12 o'clock, as long as I maintain the end plates to the side. You can see the pink end plates. There it is, right there. There's the painful annular tear right there. Now you can see how pink the end plates are on the right and left. That's because this disc is very inflamed. There's a piece of herniation there. It's kind of stuck, and I have to go in and fish it out. All right, well, for those of you watching, if you have questions, feel free to ask. That's what I'm here for. We're broadcasting surgery live so that the audience has an opportunity to ask questions. The reason I came up with this whole broadcast surgery live was because I realized my goal was to teach the world about what we do in surgery. And that's the same thing that we do for surgeons that are training. When we're training a surgeon how to do surgery and teaching them the steps of surgery and teaching them the technique of surgery, we literally have them stand next to me, the instructor, and we run them through a surgery. And we do it over and over and over again until they get it. And so I realized that if I could provide you, the audience, the lay people out there who aren't surgeons, the same opportunity that a surgeon would have in surgery to learn, that you all could have an opportunity to pick up what it is we're doing and learn about it, and even ask questions. Now, I'll tell you this, during my training, I would stand next to the surgeon and I would assist, like Luis is, and I would get to watch just like you are. And I wasn't able to ask questions because you're not allowed to really ask questions when you're operating, because surgeons don't want to really talk for the most part. But for me, I was really comfortable doing so many of these surgeries, in the years before we started broadcasting, that I realized I didn't mind asking questions. And besides, I end up playing music anyway, usually, and just singing. So if I could sing, I could talk. If I could talk, I could teach. And why waste the opportunity to teach others what we do if that opportunity is there? So that's why I decided to start streaming our surgeries and teaching the world what we do here at Deuk Spine Institute. Just about done. That's the last of the tear. Look at that thing. No disc left in this disc, but there's still a tear. It's still inflamed, and that's where the back pain comes from, that pink thing right there. So I just vaporize it with the laser, remove it. We call it a debridement. That's really what it is. We're debriding the painful tissue, the scarred up, garbagey, grungy tissue here at the back of the disc, and that takes care of the pain. Let's go ahead and run our video one more time of what the Deuk laser disc repair does here with the laser, how we do the annular debridement and get rid of all that painful inflammatory tissue to cure back pain.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, we are at the back of the annular tear and just cleaning up gobs of scar tissue with the laser. And like I said earlier, there's a little bit of fat. People ask me all the time, can you remove bone spurs with the laser? That's a bone spur right there. You tell me, can I remove bone spurs with the laser? Oh, heck yeah. The laser, the bone spur has no chance against the laser, you know. This is all bone spur. It's all just vaporized very easily. Now, if you don't use a laser, how do you remove bone spur? You got to use a drill, or you got to use biters. Very dangerous tools. We would not want to put those tools down here by the nerves. Did you guys change the irrigation? Okay, yeah, let me know. Yep, this is all bone spur. Goodbye.
James from YouTube has a question.
All right, James, we'll take your question.
After L5-S1 surgery, how long does it take to recover, especially driving long distances for a truck driver?
Well, great question, James. So James is asking, after L5-S1 surgery, how long does it take to recover? This is a great question, but James, I need to know what surgery you're talking about. Are you talking about the Deuk laser disc repair that we do here at Deuk Spine? Are you talking about a fusion or an artificial disc? Are you talking about a laminectomy, a foraminotomy, a microdiscectomy? Are you talking about an interspinous device? What exactly are you talking about? Because I need to know the procedure and sort of the diagnosis to tell you how long the recovery would be. For the Deuk laser disc repair that we're doing right now, the recovery is 1 hour. Now, truck drivers have to, you know, couple and uncouple their trailer, and that's hard to do. I think it's like 70 pounds worth of effort. So you're going to want to take it easy for probably about 3 months. And can you uncouple? Possibly. If you had a co-driver, they could do it. But you could go back to driving your truck literally within days. If we did your surgery this week, you could be truck driving next week. It's just that lifting that you have to restrict yourself from. You need time to heal. What? Question? Look at that bone spur, man. That thing is just melting. You guys talking to me? Everything okay? Is it your son?
I'll just get some medication.
Oh. All right. Great question, by the way. Just about done. I need 10 seconds more and we're done here. May be able to see the nerve here. Let's see. Sometimes we can see the nerve. It's right up here, but there's a lot of connective tissue around it. Let me just make sure that that is not going to press on it. This is just below the nerve. I just got to be really careful. There we go. That's it. Done.
Lights on, please.
So again, couldn't really see it, which is good. That means we're far enough away from it. Scope off.
Please. Thank you.
Antiseptic. Irrigation. Again, the antiseptic is brown because it's betadine. Betadine is brown in color. We do 2 washouts. Never had a single infection with this surgery. 1,400 of them over the last 16 years and not a... Hey, where's my suction, guys? I need tube suction. I need suction. No, it's not. You changed it to the bag. I need it on the line.
That too. The line, if it's connected or not.
I don't have... There.
No, yeah.
Yeah, whatever you did got a suction back. Thank you. Anyway, 16 years, 1,400 of these surgeries, and not a single infection. There's no other spine surgery in the world that has that record. So we're going to do the last disc in just a minute. Again, this will be another severely collapsed disc. Just like the last one we did, there'll be a lot of old inflammatory tissue and there won't be much soft disc left. Come on in, come on in. I'm just cleaning up. It's always a lateral. No problem. I need the guide wire. One level to do, and then, yeah. All right, any more questions, gentlemen? Shot? Looks good.
Yes, we have a question from Grace on YouTube.
Hello, Grace. Welcome to the live stream from Deuk Spine Institute. We'll take Grace's question from YouTube.
She's saying, hello, I'm a PT and I suffer from a big annular tear on my right L4-5, but my sciatic pain is on my left side. How do you approach this?
Great question. So the first thing I want to do is look at your MRI and make sure there's nothing on the left side. Why? Because radiologists miss herniations all the time. So I don't miss herniations. I would want to see your MRI. I would want to make sure your MRI has been done after your left leg sciatic symptoms started, okay? So that it would show us a herniation that would be causing those symptoms if there is a herniation causing it. Okay, so number one, look at your MRI myself. Number two, I would like to examine you virtually, but there's another cause of sciatic pain that's very common. There's a couple of more causes. One of them is the piriformis muscle, spelled Piriformis. You probably know about it, but the piriformis muscle is probably the second most common cause of sciatic pain. And it causes sciatic pain Oh, that's a tough one, huh? It causes sciatic pain. That starts in the butt cheek, and you would have tenderness of your butt cheek on the left side, severe butt cheek tenderness. So if you have tenderness of the top of your butt cheek, the upper half, to palpation, then you probably have a piriformis syndrome. If you have a piriformis syndrome, then you need a piriformis treatment, which is a shot of steroid into the muscle, followed by the therapy and basically behavioral modification not to re-injure the muscle. So my leading diagnosis is a herniation, but once I see your MRI, if there really is no herniation, then it would be the piriformis muscle. The sacroiliac joint can also cause sciatic pain because you can get inflammation spreading from the SI joint to the give me a second here, to the sciatic nerve. Then you could also have something going on in your pelvis. So if your exam doesn't show a sacroiliitis, doesn't show piriformis, and your MRI doesn't show herniation, then I would be concerned about a pelvic mass causing irritation of the sciatic nerve. So, no. Yeah, we're going to have to pull it back a little bit. Can you grab that and pull it back using your hands? Just try to twist it back. What else do we have? So I don't want to advance the dilator any further. Is he relaxed still? Yes. All right, but you're probably going to start unrelaxing him? Yeah. Is it working? Shot? No. Are you taking the top tube off? If you can get the top tube off, that's fine. If you can get the tube out, that's fine.
You want the tube out? Or
Yeah, I want the tube out.
because you're, well, yeah.
Because if I can pull the tube out,
Yeah, right.
if I can pull the tube out, then I can pull the dilator back and we can start over. Just the tube, if you can get just the tube. We may need to get a vice grip. Wait, is it coming?
There's
No?
the, picture.
Oh yeah, yeah, it's coming. All right, good. Yeah, get the tube out, and then let's pull the dilator back, and then we'll re-advance the tube. Sorry, we're just doing a little troubleshooting. Shot? So what's happened is the dilator has gone into where I want it, but as I'm putting the tube in, shot, over the dilator is moving too far forward. You have to pay attention the whole time you're doing the surgery. You don't want shot. You don't want to move that dilator too far forward, or it could end up being somewhere you don't want it. That looks better. Good job, Luis. Uh-huh. That should be it. So we're just about done. We're going to do this last disc and we'll be finished. You can start reversing him if you haven't already.
Remember that we
Oh yeah, we still have. Yeah, you're right. Maybe we should wait. 20 minutes. All right, so we've got our tube in place. And sucker what? Yeah, that's fine. Had some good questions from our audience, some good audience participation. Any more questions from the audience?
Yes. James from YouTube asked, the surgery you are doing now, how safe is not damaging the nerve roots?
How safe is not imaging the nerve roots? So James from YouTube is asking, how safe is not imaging the nerve roots? I don't know what you mean by imaging, James. I don't know what you're talking about. You mean visually seeing them?
That's bad on my part. He asked how safe is not damaging the
Oh,
nerve root.
damaging the nerve roots. Okay, I apologize. Yeah, so this is a very safe surgery because number one, you're placing the needles first. The needles are very skinny and it's easy to navigate if you know where you're going, which I do. You want to navigate to exactly the right spot around the nerve roots. So it's kind of like navigating a ship through a coral reef. As long as you know where the coral reef is and where the gap is, you can navigate the ship's hull through there. Otherwise, if the ship hits the coral reef, it's going to sink from an injury to the wall of the ship, the hull. So I know where the nerves are, and I can move that needle between them using the X-ray. So it's very safe. And then once we get the needle in the right position, the rest of it's pretty easy because it's called dilation. You're dilating and you're gradually, gently spreading tissues. So spreading tissues around the nerves is very safe. Yeah. Yep, and as I said earlier in the broadcast, I didn't come up with the technique of going in. That was developed by Dr. Cambin, Parvis Cambin, from Pittsburgh. And he even named it after himself, the Cambin's Triangle. If you look it up, you'll see on Google, K-A-M-B-I-N. Go ahead and type Cambin's Triangle in the answer so that he can look it up and understand what we do, how I get there. But yeah, it's very safe as long as the doctor knows what they're doing. And they have the right tools, the right equipment to do the surgery properly. There are a lot of doctors out there that don't. There are surgeons that will try to do this kind of surgery without investing the money and time into getting the right training or the right equipment, and they will hurt you. And I've seen it, not at Deuk Spine, but at other places. There are unfortunately still people motivated by money and not by patient well-being. That doesn't mean we don't take money, of course we do. But our primary focus at Deuk Spine is getting patients better, getting them well. So we've invested in all the best equipment over the years, and we literally have top-of-the-line equipment for these surgeries. As a matter of fact, we have better equipment here at Deuk Spine for spine surgery than at all the hospitals in this entire county. As a matter of fact, probably the state of Florida. A lot of hospitals, unfortunately, because of budgetary constraints, they just can't buy new equipment. So a lot of their equipment gets outdated, but you can still kind of do the surgery, but not really that safe. That's why I left the hospital. I left the hospital because the hospital kept trying to save money on the surgeries, and they kept cutting corners. And the patients would suffer as a result. And I couldn't stand there and watch that happen. So I decided the only way I could make sure that my patients had the very best equipment and the best supplies and the best medications and the best people was to basically own the surgery center myself, which is why I invested my own money to build this place and make sure that nobody could ever tell me you can't have that better piece of equipment or that better medication. Yeah, so it is safe as long as done right. Of course, like everything in life, right? Has to be done right. Driving a Formula One car is safe as long as you're Max Verstappen driving it. And as long as it's been engineered properly, right? But if you try to drive a Formula One car or I try to drive a Formula One car, we'll probably crash because there's a certain way to drive it. You got to put the throttle on the right way and the brakes, and it takes a lot of training and a lot of engineering, but can be done safely by the right people. All right, this is our last herniation. This is our last disc and hopefully our last herniation right here. So we should be done with the surgery momentarily. Type your questions up if you have any more. I'll be happy to answer them in the last 5-10 minutes. Why don't we go ahead and show a video of one of our patients that had the Deuk laser disc repair recently for their lower back, and let them share their experience here at Deuk Spine Institute.
Before we do, Peter from YouTube does have one question.
Absolutely.
Peter says, how many follow-ups and timing after surgery are required for out-of-state patients?
Yeah, great question, Peter. How many follow-ups in clinic are required after surgery for out-of-state patients? Yeah, great question. So first of all, we have patients from out-of-state and patients from out-of-country, not just local patients at Deuk Spine. As a matter of fact, out-of-state and out-of-country patients are about 75% of our surgery patients now. Follow-up can be done virtually over the internet if it needs to be done. Basically, there's one follow-up the next day after your surgery in the office where I check you out and make sure you're doing well. And then after that, any additional follow-ups can be done with Zoom. Great question. The reherniation rate for this surgery, that's the chance of getting another herniation where we operate, is 1%. That's the number. In 1,400 patients, we've had 14 patients that reherniated and had to have another surgery. That's a very good reherniation rate. Normally it's much higher for other types of spine surgery. Like microdiscectomy, it can be as high as 5 or 10% in the literature, and then in practice it's actually higher than that. It's probably more like 50%, but hard to capture that data. So the reherniation rate with this surgery is 1%, and there's always a chance you might need like facets treated, facet joints. Facet joints are not the disc, they're a different kind of joint. They're located behind the disc. And some patients, around 15% to 20%, need to have facet joints treated as well. So they don't just need their disc fixed, they need a facet joint rhizotomy. Most people can get that done near their home, wherever they come from. They just have an interventional pain management doctor that can do that. But we've been doing facet treatments here at Deuk Spine for 16 years, and we have some newer technology when it comes to facet treatments that is very promising to give more lasting results. All right, 30 seconds and we're done here. Type up your last questions, and then we're going to leave you with a video of a patient who traveled from Australia. You guys have that one queued up?
Yes, we do. We have one more question from Grace Bell's follow-up question on her big annual tear on her L4-L5.
Yes.
She asked, I'm 100% sure that the sciatic pain is from the narrower foramen on the left. So do you enter on both sides?
Oh, great question, Grace. Yeah, so if you have narrowing of the foramen on the left, we would enter from the left side. Unless you're having right-sided findings on exam or symptoms, in which case we would go on the right side as well. So you may have to have both sides done if the herniation is really that big. What? So I don't know if that answers your question. I would need you to submit your MRI, Grace, to mri.deukspine.com to get a good answer, an answer that we can stand behind. All right, anybody else with questions before we wrap this up?
No further questions, Doc.
Excellent, excellent. Good job, guys. Let's go ahead and leave them with one of our patients' testimonial so they can learn a little bit more about the experience here at Deuk Spine Institute. Dr. Deuk here at Deuk Spine Institute. It's Groundhog Day, I believe, right? February 2nd, so 2/2/2022. And I'm here with one of my patients who traveled from, where did you come from?
Tennessee.
Tennessee. And why would you travel from Tennessee to Florida to Deuk Spine Institute?
I have been miserable for months, and I found you and did a consult with you and knew this is where I needed to come for good treatment and relief.
And what kind of problem were you having that brought you to Deuk Spine Institute?
Severe lower back pain, which turned into sciatica, and it was down my left leg constantly. I slept about 2-3 hours a night at most, and I could not sit for more than 5 minutes, and I had to be standing up.
And did you try some other treatments in Tennessee or elsewhere?
I did. When this whole thing started and it was a bad flare, I thought I'll be able to work through this. Chiropractic, physical therapy, 2 spinal injections, massage therapy.
And how did you know those treatments did not work for you?
I had no relief at all. My sleeping continued to get worse, and my pain was never better.
And do you have relief now?
Absolutely. I would say I have 95% relief.
Awesome.
And it's amazing. After surgery yesterday, I put on a back brace. I walked out of here. I sat down yesterday for probably over an hour and had lunch. Last night, in bed, I had 0 pain. It's a miracle.
Well, we're very happy that you're doing so well. And your surgery was a great one because we fixed 2 discs. You had herniated disc at L4-5, L5-S1. And you can see in this footage right here that we grabbed the herniation out. And it was one of the herniations was really big. And it was really gratifying to get it off because it was resting on your sciatic nerve. Once we took it out, I think your sciatic nerve probably felt a sigh of relief.
Yes, absolutely.
Yeah, and the surgery went very well. The laser debridement of the annulus went well. And I feel like your pain's going to be gone. It's not going to come back.
I would agree.
All right, very good. Well, is there anything else you want to tell your viewers?
Folks, if you're suffering and you're not getting relief from those non-invasive therapies, then come see Dr. Deuk and have him look at your MRI and give a good diagnosis. And if you need to have surgery, you come down here. He will take good care of you, and so will his team.
I really appreciate that. Thank you so much.
Thank you.
I'm Dr. Deuk. It's January 26, 2022, and I'm here with one of my patients who you underwent the Deuk laser disc repair on your lower back for some herniated discs about a week ago.
Yes.
How are you feeling today?
Unbelievable. For almost 3 years, I had lower back pain, and it just, it just nags at you, wears you out. And then I came here, and you were the first one. I went to 2 other surgeons, and neither one of them picked up what was wrong with me, even though I had the MRI. And you came in, and you told me exactly what was going on, and you performed the laser surgery, and I'm like a different person.
Yeah.
A week later.
Yeah, you were a different person the next day, right? The day after, you had no pain, remember?
Absolutely.
Yeah, so that pain's gone for the rest of your life. How does that make you feel?
New life.
Good. And, a long time ago, remember when people did something great, you say, what are you going to do now? They say, I'm going to Disneyland. You already went, I can see.
No, my wife's a big Disneyland fan.
Good for you. All right, so sounds like we helped you with your back pain, and it sounds like you're very satisfied.
Oh yeah, I'm recommending a friend of mine in Connecticut to come here. You have to come here. If you go anywhere else, I really think you're going to be wasting your time. So this guy just looks at you and he can tell what needs to be done. He's a fantastic talent, and I'm very grateful that I came here.
Well, we're grateful you did too, because it's going to change your life for the better. Congratulations.
Thank you, Doc.
You're welcome. Good morning, I'm Dr. Deuk Major, and I'm here with one of my patients, and you traveled to Duke Spine Institute here in Florida from where?
New York, Poughkeepsie, New York.
Awesome. And why did you come from New York to Duke Spine here in Florida?
Because I heard that this was the best place for me to go.
What kind of problems were you having that you needed to come here?
I had lower back problems and numbness in my leg, which was my left leg. This was the best place for me to come.
Okay, so you had back pain, sciatica down your left leg, pain shooting down the left leg.
Yes.
And that was just yesterday, right? When you
yes,
had
that's
that.
correct. Yeah.
And what, do you still have your back pain today?
No more back pain.
It's gone.
Gone.
And is that because we have you doped up on powerful painkillers?
Nope. None
No, it
whatsoever.
isn't. Did anybody in New York offer you spine surgery to fix your back?
Yep. Yes, they did.
Yeah.
And they wanted to fuse it.
Yeah. And you've had surgery before. You had a microdiscectomy, and that helped you for a little while,
Yes.
but the symptoms came back.
Came back.
Yeah. All right, well, they're not going to come back this time. So what do we do to make your pain go away?
You fixed my back. I did arthroscopic.
That's right, arthroscopic spine surgery called the Deuk laser disc repair. So leg pain's gone, back pain's gone.
Everything is gone.
You happy?
You did. Very happy.
You're smiling.
Yeah. I tell you.
Congratulations.
Thank you so much.
We did it all through a 7mm incision, just that big. And you can actually watch that video right here, an animation, to see what it looks like to do the Deuk laser disc repair.
A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own.
So now that your surgery's done, what are you going to do?
I'm going to go home and enjoy my life.
Good for you.
Enjoy my life.
Congratulations.
I'm very happy.
Anything you want to tell your viewers?
Other than this is the place to come, it's worth the travel.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Deuk Laser Disc Repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery, and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated,